Hello, everyone. We're going to be talking about opioid use disorders and how to manage them in urgent care. So let's start with a simple case. A 23-year-old chronic fentanyl user comes in. They've stopped their opioid use abruptly. They're tachycardic, flushed, tremulous, and they're seeking help. So clearly they're in opioid withdrawal. Now, it's important to know that quitting cold turkey is associated with a high risk of relapse, morbidity, and mortality. So you need to know how to respond to these patients. Many of these patients have a lot of mistrust of the health system. They feel stigmatized and they feel judged. And so it's really important that we're careful about the language that we use. It's important to try and build rapport with them. You need to be empathetic. I'm glad you came in. I'd like to help you. You should reassure them that there are effective treatments that are available. Treating an opioid use disorder is very similar to treating any other disease like sepsis or any other condition. The patient is suffering, they need our help, and they have a disease that you can provide effective treatments for. The language that you use should be carefully chosen. You want to avoid using terms like addict and avoid placing blame or fault on them. These patients are here needing help, and they have an opioid use disorder, which is a perfectly treatable condition. It's important to establish clear boundaries at the start of your interaction so that you're not going to be prescribing opioids in this visit other than an opioid agonist therapy agent, but you won't be prescribing fentanyl or morphine or hydromorphone or any other agent. You need to approach that patient encounter with understanding. Many times, patient encounters can be difficult. They can be challenging because they escalate very easily. They can get argumentative. It's important to know that they're not being difficult by choice. Much like a delirium patient, they're suffering from their withdrawal, and that's why they're acting out, and they're not trying to act out. So you need to be very compassionate and empathetic. It's important to know that opioid use disorders most often start from a true pain issue, whether that pain be a mental health pain or a physical injury that eventually developed into a dependence and then into an addiction. It's also important to know that what you're doing, like Mel Herbert says, what you do matters. What you're going to be doing is providing them a safer alternative than the street supply of opioids that they're going to be receiving. So what is an addiction? Well, an addiction is more than just a physical dependence to a substance. It's also associated with a loss of control in the amount and the frequency of use. It's associated with cravings and compulsions. You spend a large amount of time, an inordinate amount of time and effort trying to get more of the substance, and you use the substance despite knowing the consequences that you will suffer from using that substance. You have no control over it. There is a DSM-5 criteria on opioid use disorders. If you have a scoring of 3 or less, it's mild, 5 or less, it's moderate, 6 or more, it's severe. But you don't need to worry about this. This is not really critical. You're not going to be diagnosing the opioid use disorder. All you need to know is your patient came in, they're an opioid user, they're in withdrawal. How do I treat this? So I wouldn't worry too much about this portion. What treatments can you offer? Multimodal treatments are: one, you need to make sure that you provide all of these patients with a naloxone kit, a take-home naloxone kit. All you have to write on the prescription is THNK. And each kit comes with 3 doses of naloxone, an auto-retractable needle, a mask for safe rescue breathing, and instructions for any bystander that's there to help the patient. It's extremely important to do this because of the fact that many of these patients may relapse, and you need to have something safe there. You also want to make sure that you offer them counseling and refer them to an addictions program and start them on an opioid agonist therapy agent. It's important to know all of this because not only for our patients, but AHS also expects us to be able to screen for opioid use disorders. They expect us to initiate opioid agonist therapy and to arrange follow-up and continued management for these patients. So it is important for us to all be very comfortable with Suboxone and Methadone and understanding what these drugs are and when to prescribe Suboxone and how to do it. So what are the major agents? Opioid agonist therapy, the goal is to decrease your withdrawal symptoms and decrease your cravings. Two major agents are Suboxone and Methadone. Suboxone is the agent that you're going to be prescribing, and each tablet comes in with 2 milligrams of buprenorphine and 0.5 milligram of naloxone. Focusing on the naloxone component of Suboxone, the naloxone component has minimal to no absorption. If you take it sublingual as prescribed or PO, it has no physical effect on you. It's only in the pill because if a patient tries to abuse the drug by crushing it and injecting it, snorting it, the naloxone will become active and it reverses the buprenorphine and it'll trigger the patient into withdrawal. That's why the naloxone is in the pill, and it makes Suboxone very effective, but also it makes a patient not ever want to crush or use Suboxone pills in an inappropriate manner because it actually worsens their symptoms. Trying to separate out the naloxone is an extremely tedious process without any real reward, because now if we focus on the Suboxone component, it's a long-acting mu receptor agonist. So it's very long acting. Duration is 24 to 69 hours. The average elimination half-life is 37 hours, sublingual dosing, but its onset is pretty quick, 30 to 45 minutes. So you can get effect pretty quickly, and it lasts in your system for a long time. There's no triplicate required. You can write it on a regular prescription pad, and the dose is very straightforward. From day 2 onwards, once you've found the maintenance dose of Suboxone required, it's once a day in the morning. You take your once a day in the morning Suboxone and you're gold. Suboxone is safe. It's a high affinity, low activity drug. What that means is it's a mu receptor agonist, and therefore it reduces your withdrawal symptoms, but it's a partial agonist. Because it's a partial agonist, it has a ceiling effect. You can't overdose on it. It has a very limited respiratory depression and limited euphoria. And it has a stronger affinity for the mu receptor than full agonists. Therefore, it outcompetes other opioids. So if you try and take fentanyl or methadone or morphine or any other opioid, it will outcompete those opioids. It also is a kappa receptor antagonist, so it decreases your cravings. The risks of using a Suboxone is it can trigger precipitated withdrawal. That's the number one thing that we need to be aware of when we're dealing with initiating patients on Suboxone in Emerge. Because of the fact that it outcompetes other mu agonists, including fentanyl, morphine, and others, you must achieve the maintenance dose of Suboxone, otherwise it'll trigger withdrawal. Suboxone has a risk of sedation as well if you combine it with other sedatives. You're not going to be overly sedated on Suboxone alone, but if you combine it with other benzos or alcohol or other sedating agents, then there's a risk of sedation. You need to counsel your patients about that. So what is the criteria for starting Suboxone? You need to be in withdrawal. Number one, you need to have other opioids out of the system because, as we mentioned earlier, Suboxone will outcompete other mu agonists. So if you have fentanyl in your system and you start taking Suboxone, that fentanyl will be outcompeted by Suboxone and it'll worsen your withdrawal. So you need to have other opioids out of your system. There should be no short-acting opioids in your system for the last 12 hours, no long-acting opioids in your system for 24 hours, and no methadone for 72 hours because of how long-acting methadone is. Now, what happens if a patient isn't truthful about the timing of their last opioid use? Well, most likely they'll go into precipitated withdrawal. You'll give them Suboxone and their withdrawal gets worse. Now, it's a self-limited condition. It's not dangerous. It's just uncomfortable for the patient. That's why it's so important to be very upfront with the patient and explain to them, I'm not judging you about the timing of your last opioid use. I just don't want to make your withdrawal worse. So I need you to be very upfront with me on when you last used an opioid so that I can give you Suboxone safely. Remember that if a patient comes in an opioid overdose, we give them full dose Narcan and induce them into opioid withdrawal. It's just uncomfortable. It's not dangerous, not harmful. The treatment, if a patient goes into precipitated withdrawal, so you worsen their withdrawal symptoms by giving them Suboxone, the treatment is just give them more Suboxone, because eventually you will reach that steady state dose that they need, and they will no longer be in withdrawal. So what you do is you just increase the number of tabs and the frequency of their tabs to get them out of withdrawal. If you need any help, then you can always, through Rapid, call the addictions medicine specialist for advice. So how do you dose Suboxone? Number one is you take a COWS score. A COWS score is a withdrawal severity score. You're not going to be doing this. The nurse is going to be doing this. It's a very straightforward thing, though, where the COWS score is just basically counting up your withdrawal symptoms. All the typical symptoms that you consider when you're diagnosing someone as an opioid withdrawal: goosebumps, mydriasis, diaphoresis, stuffy nose, yawning, body aches. The symptoms that make you think they're in withdrawal, you're just counting those symptoms up to get your COWS score. If your COWS score is less than 12, you can actually send them home and have them initiate their Suboxone at home. You give them a prescription of 1 tablet Q1H PRN, and you just instruct the patient to take the tablet sublingual only until they feel better. So when their withdrawal symptoms are getting under control, then they can stop. They don't need to continue taking more. And the HS protocol that I've attached to this email says that you send them home with a prescription for 6 tablets, but you can give more. Many addiction specialists on day one, when you're trying to titrate these patients, they start them on 12 tablets on that first day, just so that they have enough to try and get that homeostatic maintenance dose. So you give them 1 tablet every hour until they no longer are feeling that they're in withdrawal. That is their steady state dose. That's the same total amount of dose that they'll use on day 2. And you give them a 3-day supply to ensure that they have coverage until their follow-up appointment. If their COWS score is more than 12, then you initiate their Suboxone in Emerge or urgent care. What you do is you give them 1 tablet, reassess them in 1 hour to make sure that they haven't gone into precipitated withdrawal, they haven't developed an allergic reaction. If everything's fine, you now give them 2 tablets and you recess them in an hour again. So after that second dose, in an hour you check, and if they're doing well, you send them home with a prescription. I usually send them home with prescriptions of 12 tablets a day, and that gives them plenty of coverage until their follow-up appointment. If you have a PEDS patient or a pregnant patient, you can call the addiction services online, but just be aware that there is no change. Suboxone is completely safe to use in pregnant patients and pediatric patients, and the dosing regimen is exactly the same. But using the addiction services online is very helpful for these high-risk patients. Suboxone dosing, now the maximum you should use is 32 milligrams a day. That's 16 tablets. That's because that is when 99% of your receptors are occupied. And so there's no harm to taking more than 32 milligrams. It's just that there's no interval benefit because you've already maxed out your receptors by then. The vast majority of patients stabilize at 24 milligrams a day or less, which is 12 tablets a day or less. So on day one, your goal is to just give them tablets once an hour until you and titrate to effect. That whatever the total amount they took on that first day is now their maintenance dose that they take from day 2 onwards, once a day in the morning. If you have a pregnant patient, opioid withdrawal, it puts their fetus at high risk because of placental insufficiency, growth restriction, premature rupture of membranes, premature labor. So you want to avoid withdrawal at all costs. Methadone and Suboxone are both completely safe in pregnancy, and so you shouldn't try and switch categories. If the patient's already on methadone, continue on methadone. If they're not on any opioid agonist therapy agent, then you should start them on Suboxone. You should also call the OB on call because this would be a high-risk pregnancy and they need to be followed. As well, I would consult the opioid consult service. Just call Rapid. They're open 8 a.m. to 8 p.m. 7 days a week, including stat holidays. That's when the addiction specialist will answer the phone. They'll arrange for rapid follow-up for these patients, and they'll help you on the phone with dosing or any questions you have. So in terms of follow-up resources that are available, for the physician, there's the addiction medicine consult that's available through Rapid or Specialist Link. For patients, there's an addictions helpline that's available 24/7. And there are multiple outpatient clinics that I've attached to the email. Your job is simply to just fax the referral sheet and tell the patient to attend the next day with their prescription. Now, options in the Calgary zone or Calgary area is there's in person, there's the Schumer Clinic, the ACT Clinic, the RAM Clinic, as well as if you're outside the Calgary zone or and anywhere in Alberta, there's the virtual ODP clinic that's available. What'll happen is you give them the phone number, and within 24 hours, a physician will be calling the patient directly and discussing how things are going, discussing their maintenance dose, and getting them set up with counseling, as well as writing them a prescription for all subsequent dosing of their Suboxone. I'd like to highlight the RAM Clinic in particular because it is extremely well run. The RAM Clinic, it covers all of the Calgary zone, so Banff, Okotoks, High River, and other areas. It does not just opioids, but other substances, including alcohol, cannabis, methamphetamines, etc., and other addictions like gambling, video games, and so forth. And their follow-up time is excellent. It's next business day on average. So they have very, very rapid follow-up, extremely well-run clinic with a full gamut of resources available to these patients. If any of you know, Monty Ghosh is the physician who's running this, and he's outstanding and very passionate about what he does. And I think we should all support this RAM Clinic. And I'll be putting up a poster about the RAM Clinic in our department soon. Other drugs that you should be aware of that you've heard of and often used in the past, I'll discuss now. Clonidine, it's fallen out of favor. You lose opioid tolerance. So by losing your opioid tolerance from using clonidine, it increases your risk of precipitating an opioid overdose. For example, let's say you have a chronic fentanyl user who uses 2 milligrams a day, and then you give them clonidine. If they reuse 2 milligrams of fentanyl, then their regular dose, they're at risk of overdosing, not just with one dose of clonidine, but if you give them several doses of clonidine, then it can reduce their opioid tolerance and precipitate an overdose from their opioid and even cause death from the dose that they're usually used to taking. Methadone is not first-line agent. Suboxone is a first-line agent, But if they're already on methadone, you should keep them on it. If you really need to change them, then the process, it's a slow taper. So you're going to slowly taper them off their methadone and then start them on Suboxone when it's out of their system for at least 72 hours. But this is not something you're going to be doing. This is something that an addiction specialist is going to be doing at the RAM clinic. The pros of methadone is that it stabilizes cravings because it's a kappa receptor antagonist like Suboxone, and it's got a long half-life like Suboxone, so it decreases your withdrawal risk. But the con is that unlike Suboxone, it's a full mu agonist. So there is a risk of overdose and abuse, and it also reduces your tolerance to opioids. So similar to clonidine, you can overdose on your regular opioid because the methadone reduces your tolerance to opioids. The Alberta methadone guidelines say that if you miss a dose of methadone, you're supposed to reduce the dose by 25%. But a patient's not going to always do that. In Suboxone, that's not something you have to worry about at all. So in summary, opioid use disorders, you should treat as any other disease. You want to avoid stigmatizing these patients or arguing with these patients. You want to understand where they're coming from and be glad that they came in for help, and be glad because this is a totally treatable condition. Suboxone is your first line agent. It's safe and effective for all patients. It's extremely important, and AHS expects us to be comfortable with initiating Suboxone in urgent care and getting them treated, as well as arranging outpatient resources. And there are multiple resources available, and I'll be attaching all of these links in your email. Thank you.